All right, thank you for having me. Is this okay? Hi, everyone. Good morning. Thank you. I'll get started. So I'm a rheumatologist at Virginia Mason. I do not have any disclosures. I have a lot of topics today that are in this slide deck that we may or may not get covered. We don't have a lot of guidelines in rheumatology. It's sort of a free-for-all because we don't have a lot of data because our diseases are rare. And so when we get guidelines, we get very excited. So I've included all of our new guidelines and I've included little links to them. So if you want to click through later, if we don't necessarily cover them, they're available to you. I included a few new medications that we've had coming out or new indications for old medications, a new disease that we have uncovered in the last year, basically. And then we'll go over some vaccination guidelines. And I tried to pull things that I thought would be a little more generally applicable to all of us here. So we'll start with a case. We have a 73-year-old woman. She has well-controlled diabetes, hyperlipidemia, hypertension. She's coming in with 3 weeks, pretty sudden onset shoulder, neck, low back pain. It's there most prominently in the morning. It's this deep stiffness sensation. It will get better if she goes for a 2-mile walk or takes an ibuprofen. Maybe some fever is low grade, no weight loss, no joint involvement, no rashes. She's on metformin, statin, lisinopril, amlodipine at baseline. On exam, she looks a little uncomfortable, but she doesn't have any joint swelling. Her muscle strength is completely intact. She's got just this kind of myofascial tenderness over the trapezius, over the deltoids, maybe a little bit over the gluteal area. She's got good temporal pulses. Heart and lung exam is normal. So for this patient, my differential as a rheumatologist, and probably for those of us who are practicing primary care, number one on the list would be polymyalgia rheumatica, not to give it away at the jump. But other things that I would consider as a rheumatologist would be rheumatoid arthritis. We wouldn't really expect rheumatoid arthritis to show up without joint involvement. Obviously, that's a hallmark of rheumatoid arthritis, but sometimes early RA can show up looking a lot like this. Maybe this is more of a multifocal local musculoskeletal disease, meaning like pulled muscle here, pulled muscle there. It can happen. A little weird for it to be happening upper and lower, but we always think about that. Is this some sort of autoimmune inflammatory myositis? Now, a myositis, an inflammatory myositis, really should not have much pain associated with it. It really should be mostly proximal muscle weakness, but we never want to miss that. And then maybe this is not actually at the muscle level at all. Maybe this is happening in the bones. And so I'm always wondering, is this maybe some Paget's, multiple myeloma, hyperparathyroidism, osteomalacia? Is this perhaps more of a drug-induced myositis, so not necessarily autoimmune in nature? Is this because she's on a statin? Maybe she was recently started on a checkpoint inhibitor for a cancer. Other medications that can cause this that we know of are antivirals, antipsychotic medications, anti-malarial medications, heavy alcohol use, cocaine. Fibromyalgia, of course, can also present looking a lot like this, although usually not as sudden onset and usually not with these other symptomatic symptoms with like the fevers and whatnot. Could this be some sort of infection? People get a lot of muscle aches and they get low-grade fevers when they have different types of infections. We never want to miss that in rheumatology. Could this be a spondyloarthropathy? Because this is a very axillary predominant situation she has here with shoulders, hips. So is this like a ankylosing spondylitis? Pretty unlikely for a 73-year-old to wake up one morning with ankylosing spondylitis, but that's what I'm thinking about. And then the super rare stuff that we always just sort of have in the back of our mind, but I have seen, an atypical presentation of Parkinson's, hypothyroidism, malignancy, vasculitis. So the point here is a lot of things can show up looking like this, and we're going to try to tease out how to prove that this is polymyalgia rheumatica. So I don't think anyone can actually see this, and that's fine. I put the link to this at the bottom of the page here. It's a very nice little PDF. This is an old paper from Arthritis and Rheumatology, but it's a nice way, I think, of thinking about and classifying proximal pain and stiffness into inflammatory and non-inflammatory, which is what I spend my entire month long with each internal medicine resident doing, is trying to get them to understand the difference between inflammatory and non-inflammatory pain. And so I found this as I was putting together this talk, and I just couldn't resist including it. So here you have it for future learning. So in this particular case with this lady who we've talked about, which lab test do you think would be the most helpful in this case if we had to pick one to get us our diagnosis, to make us feel a little bit more comfortable labeling her? You can tell me, or you can just think about it. I have a vote for CRP, which I love to hear. Okay. So I agree that CRP would be extremely helpful. And so before we go into why that is, I'll just refer you back to, actually, these are old guidelines, but sometimes old guidelines hang in there for a little while. So just to remind us that PMR is really exclusively a disease of people over the age of 50. I really do not want to see PMR diagnosed in 30, 40-year-olds. And honestly, if you have a 50-year-old with PMR, I would take a step back and really think about that diagnosis. This is something that I'm expecting to see in people in their 70s and 80s typically. We want to see this happening basically with morning stiffness, and that is more than 45 minutes. We want to see this involving, by definition, the shoulders. And then by definition, they have to have an abnormal ESR or CRP. So that's just to walk into the door, be over 50, shoulder aching, and an elevated ESR and CRP. Now, our gentleman in the front is right that if we had to pick between an ESR and a CRP, which I don't think we should have to pick, if you're going to order an ESR, you should always be ordering a CRP because they are testing slightly different things, and I do want to know if they're discordant. So always order those together if you're going to be ordering one. An elevated ESR is present in 92 to 94% of patients with PMR. And an elevated CRP is present in 99% of patients with PMR. We don't get 99% in almost anything in rheumatology, though this is very exciting. So that is the test to have. All right, so these are the tests that we end up getting for her. Her ESR is high, her CRP is high. She has maybe a little bit of anemia, which we do expect to see in people who have had some amount of chronic inflammation, as well as some thrombocytosis. She's got, fortunately, normal liver, kidney function, normal calcium. We do check a CPK level, although it's not a diagnostic test. I always like to get a CPK level. I would hate to miss some sort of statin-induced myositis in these people. I always do check a rheumatoid factor and CCP. You know, they're easy enough tests to get. And sometimes these people this can be the initial presentation for rheumatoid arthritis. That's helpful to know. And then plus minus, depending on what's going on and other symptoms and my suspicion, often I'll get a TSH and SPEP looking for, hematologic malignancies. If I have any sort of suspicion, like the calcium is a little out of whack, I'll be getting a PTH. If I have some sort of suspicion for infection, obviously we'll be doing the infectious workup, or, a UA if we have any concerns there. So these are our updates to the diagnostic criteria for PMR. And basically what has changed in the last few years is we've been able to add on the use of musculoskeletal ultrasound. And MSK ultrasound is something that you'll see being involved in almost every part of rheumatology over the last few years, including in PMR diagnosis. So we can now look in ultrasound and see if we find bursitis in the subdeltoids, or the bursa, tenosynovitis, glenohumeral synovitis, and or greater trochanteric bursitis. And those will buy you 2 points if you have that in both areas. So it's not enough to buy you a diagnosis alone, but in addition to the other criteria. So previously, imaging was not part of our PMR diagnostic criteria, and the ultrasound is now part of it, but there are some other modalities as well that can be used that we're learning a little bit more about. And I'm not going to suggest you're MRIing people and PET CTing people, but we're learning a little bit more about what you would find on MRI. And basically, we're seeing that PMR is not a joint issue. It is an extracapsular issue. So you're seeing a bursitis, you're seeing a tendinitis happening, and it's going to be bilateral. It's going to be upper and lower extremity. And so if you happen to catch this on somebody who's complaining of a variety of kind of non-specific symptoms, and you're thinking about it, and you check an ESR and CRP and they're high, and you give them a little prednisone, they get better, then there you go. All right. So for this lady, we start her on 15 milligrams of prednisone, which is the amount of prednisone to start in someone who has PMR, nothing higher. She immediately feels 99% better. This is the only time people ever call my office to report good news because they feel so much better so quickly. It is the most gratifying thing to treat. By definition, if people are not getting better in 1 or 2 days on prednisone, they don't have PMR. So she's doing well on it. She comes back to clinic 6 weeks later. I personally always like to repeat the ESR and CRP to see that they have fallen. I think it's nice to get a new baseline to know that where we are now, so that if down the road we have some new symptoms, maybe this is a flare, then I can repeat the labs. I see them come up. I know they were down. Okay, this is very clearly a change. You don't necessarily have to do it, but I like to. So what are our next steps for this lady? So the recommendation for tapering prednisone is basically we want to get them to 10 milligrams of prednisone over 1 to 2 months. So usually what I do is a month on 15, a month on 12.5, and then they go to 10 after that. Once they're doing well on that, then we come down by 1 milligram every 4 weeks or so. Sometimes people end up on sort of weird schedules because they have different amounts of prednisone. So the other schedule sometimes I see is going down by 2.5 milligrams on alternate days. That just gets confusing. Anyways, I do it going down by 1 milligram once a month until you're off. When people don't do well with their prednisone taper, 99% of the time, it's just because they went too fast. And so they come into my office for relapsing PMR, and we just go back to their last dose and start slower, and then they're fixed. And we do suggest using a single dose, so a single daily dose. I know a lot of other specialties, maybe we'll hear about this with asthma later, but a lot of other specialties like to split doses of prednisone. When we're using a lowish dose like this, we want to try to keep it as physiologic as possible, because also they're going to be on this for such a long time, over a year. So we're really trying to stick with kind of the physiologic cortisol levels. So really, ideally, people will take all of their prednisone in one dose first thing in the morning with a little bit of food. All right, so 6 months later, she comes back, been doing pretty well. She's down to 7 milligrams of prednisone, but now she is having a little bit more achy shoulder pain, no headaches, no scalp tenderness, a little bit of hand stiffness. Her ESR and CRP are up. What are our next steps here? So basically, she's having a relapse. She's having a flare. This is okay. This is common. 50% of people with PMR will have a relapse. And usually, in my experience, this happens around 7 milligrams for whatever reason. So what do we do now? So if this is their first relapse, honestly, what I do is just go back up to whatever their last dose of prednisone was for a month and then try again. And I would say about 50% of the time that does the trick and we're able to sail off. But what do we do with the other 50% of people? And this is where we are getting some major breakthroughs, very exciting things happening. So over the last couple of years, we have been looking at using IL-6 inhibitors in polymyalgia rheumatica. So there's 2 IL-6 inhibitors that are on the market. Sarlizumab, which is Kevzara, tocilizumab, which is Actemra. You may be familiar with these because we have also been using them to treat COVID for a while. So there's two little studies here that I reference, and then JAK inhibitors. So these are medicines like Xeljanz and Rinvoq, which we're treating all sorts of things like rheumatoid arthritis, psoriasis, psoriatic arthritis, ankylosing spondylitis, alopecia. And so we're looking at these to treat PMR. Why are we doing this? Because we have FDA approval, and I'll talk a little bit more about this, to treat giant cell arteritis with tocilizumab. So we've sort of extrapolated that it should make sense to use tocilizumab to treat PMR. And then I don't know what happened with the people who make tocilizumab, but they got beat to market by the people who make Kevzara. And actually, the sarlizumab was FDA approved to treat PMR in February of this year. And this is crazy. This is the first biologic that has been approved for PMR. This is the only non-steroid medication that we have. So this is a really big deal in rheumatology. And we don't exactly know how we're going to use this, to be honest. So I would hesitate for everyone to go out and tell your patients that you can go to your rheumatologist and get put on a biologic for your PMR and we're going to fix it. We haven't figured out exactly what the patient population is that's best for this. But this is really exciting because we certainly do have maybe 10% of our PMR patients who end up getting stuck on some amount of prednisone. And heretofore, we've tried methotrexate, we've tried hydroxychloroquine. It never works. They just end up on 5 milligrams of prednisone for the rest of their lives. And so I think those people, that 10% of people, are the people who we will end up trying on one of these IL-6 inhibitors. So we'll stay tuned for that. I included this study here if you're interested with the link at the bottom. It was actually a very small study that ended up getting them FDA approval, but it's pretty impressive. Basically, they still use 14 weeks of steroid, but they taper them off very quickly after that. And then basically are able to show a sustained response off of steroid at a year mark. So over 60% of people were able to avoid a relapse, meaning a flare of symptoms or elevation of CRP. Now, there are obviously side effects and things that come along with being on a biologic, which is why we're not going to just be putting every single person on sarlizumab. Also, it's a injectable biologic, which probably will, for RA indication at least, it costs about $10,000 a month. Prednisone costs $50 a month. So another reason it's going to be a little bit of a hard sell. Medicare, which most of my patients who have PMR are on, does not cover auto-injectors very well. For some reason, they cover infusion-based medications well. This does not come in as an infusion. I have no idea how I'm going to get this covered for my patients. So there's a lot of things to figure out. Also, one of the contraindications to being on any IL-6 inhibitor is if you have a history of diverticulitis. And we've extrapolated that also. So if I know you have pretty severe diverticular disease, I'm a little hesitant to use this because we cause GI perforations. So there's a whole bunch of people who are just not candidates for this medication. So again, please don't tell people we fixed PMR, but we have something in our wheelhouse now that's exciting. All right, let's do another case. So this is another 77-year-old lady. She was just diagnosed with PMR by her primary care doctor. She ran out of prednisone, though, a couple weeks ago. There was a little bit of a mix-up in the refill situation. So she's coming back. She has some hip and shoulder pain that came back. And now she also has these really severe headaches over her right temporal area and some tingling in the scalp. We do her labs today. Her ESR, her CRP are high, basically similar labs as we saw in our other case. So she has GCA, or giant cell arteritis. What percentage of patients with PMR will go on to develop GCA, giant cell arteritis? All right. So about 10 to 20% of PMR patients will experience GCA at some point. And usually PMR comes first, but not always. Conversely, PMR symptoms happen in about 50% of patients with GCA. So we really almost expect PMR symptoms in GCA patients, but we're looking out for GCA symptoms in our PMR patients. And, 10% is not too high, but it's high enough. And GCA is a devastating enough condition that for my PMR patients, when I'm seeing them in their routine follow-ups, I ask them at every single visit, are you having headaches? Are you having scalp tenderness? Are you having achy discomfort in your jaw when you're chewing? And then obviously, if you have any vision changes ever, you are going to the emergency room to get high doses of IV steroid. Now, similarly, GCA is diagnosed based on very high markers of inflammation, ESR-CRP. In 2022, we got updated classification criteria for GCA. So I've linked these here if you happen to be interested. Similarly, with the PMR updates, the updates really just include imaging now, which we didn't used to have. So we now include, in addition to the clinical criteria, we include people who have ultrasound evidence of giant cell arteritis or a temporal artery biopsy. And then they can also have a positive PET scan through their aorta. I have yet to just order a PET scan for the purpose of this, but it's on there. It is a little controversial still, I will say, in the rheumatology world, whether ultrasound should be replacing biopsy completely. And I personally don't think it is. I would still like to see a biopsy on every GCA patient if it is at all feasible, because you are committing a GCA patient right now to about 1.5 years of steroid and or a biologic medication. And I would really like to be pretty firm in that diagnosis before we go down that route. And ultrasound, while very valuable, is highly operator dependent. And we have gotten positive ultrasounds or negative ultrasounds from other places that when we send them over to our ultrasonographers, they get a different read. And it's just something you don't want to miss, because people can go permanently blind if you miss that diagnosis. So again, I would highly recommend getting a temporal artery biopsy if you have a reasonable clinical suspicion. What's nice also is you have 2 weeks to do the biopsy. So if you have a high suspicion, you have a 75-year-old who has some PMR symptoms, who has a temporal headache, who has a high ESR-CRP, you're going to start them on treatment, which is 60 milligrams of prednisone in your office that day, assuming they have no eye involvement. You're going to start them on treatment, and then you're going to set them up for a biopsy to be done within the next, ideally, week. We can do a unilateral biopsy. Doing a bilateral biopsy adds a little bit more, but not a bunch. And so it's fine with me if you want to do one side. Basically, it adds about 5% yield to do both sides. And then it's also nice to do a biopsy because every now and then, and this has definitely happened to me, we'll actually find something else that in retrospect explains all these symptoms. So I have found an ANCA vasculitis, I have found lymphoma, I have found sarcoid, we have found basically post-infectious changes on these things. And so that's nice because then you don't have to commit these people to the treatment for GCA. So this is an example of ultrasound in GCA. The difference in ultrasound is it is much more sensitive, which means it has to be done within a week of starting steroid, or else you will lose the potential to see those changes. What we're looking for is a halo sign, which basically you're seeing thickening of the artery here. And so because you have so much thickening of the artery, it's so inflamed that where the blood flow is smaller, you're getting all of this edema around it. So that's a halo sign. A compression sign basically means you can't compress the artery if you're pressing on it hard. And we look in all of the large vessels. So what the benefit of ultrasound is you can look in a lot more places. And so that is nice. And so I think there is value, if at all possible, in actually doing both an ultrasound and a biopsy. And that would be ideal if possible. So if I have a low suspicion, like I have a 55-year-old minimal ESR elevation, an alternate cause for that, like maybe they also have a UTI, so maybe I can explain that away. They've had this headache that's going on for longer than I would expect with GCA, but gosh, it's just right on the temple, so I want to make sure. That's where I'll get an ultrasound, and if it's negative, I feel good. I've ruled that out, and I can move on. If I have a very high suspicion, I have a 75-year-old, I have high CRP, they have bilateral, pretty sudden onset temporal headache and PMR symptoms, and I get a negative ultrasound, I don't actually care. I'm still going to treat them. I'm still going to get a biopsy, because the ultrasound is not perfect. But the ultrasound will look at all of our large vessels. So it'll look at our temporal artery, and then they'll also do the axillary artery. And if you want, they can pretty well get into the subclavian. Obviously, the clavicle is blocking it. But if you have a good ultrasonographer, they can do a better job looking at your large vessels and cover a bigger surface area. This I included just sort of as a heads up to all of us. This was a very small study that was presented at the American College of Rheumatology meeting last year, just looking at the prevalence of subclinical GCA in newly diagnosed PMR patients. So this is patients who are diagnosed with PMR. You ask them if they have any GCA symptoms. They deny it, but they do the ultrasound protocol. And in 25 of those patients, 5 or 20% had subclinical GCA on their ultrasound. So that's terrifying to me that we're missing a lot of GCA. And so that just tells me that we really need to be doing a very good job asking these patients about GCA symptoms at every visit. And maybe, I don't know, thinking about using ultrasound a little more liberally in our PMR patients. This is just a slide to remind us of the treatment for GCA. I'm not going to get into it too deeply, but basically just as a reminder, the treatment for GCA depends on if we have visual involvement or not. If we do have any sort of flickering of a visual involvement, obviously very nice to have an ophthalmologist do a proper eye exam and confirm that for us. But regardless, we can't waste time because it's often irreversible. If they have any visual symptoms, they need several grams of IV Solumedrol, and then they get put on 1 milligram per kilogram of prednisone. If they have no ocular involvement, then you can treat them as an outpatient. They just get put on 1 milligram per kilogram of prednisone, and then you call a rheumatologist, and then we'll take it from there. These are the treatment guidelines that came out about 2 years ago. I just included this because tocilizumab, which is one of those IL-6 inhibitors I was referring to before, this has been FDA approved to treat GCA. This is not the one that's approved to treat PMR for some reason, but we're using this more and more. So this was FDA approved in 2017. So unlike sirolimus, we've kind of figured this out a little bit better. Now we're using this not in all GCA patients, but definitely in all GCA patients who have visual involvement. They will get put on tocilizumab early, basically within the first month. And then we're using it for any GCA patient who has a relapse of their GCA symptoms. And then I'm using it for any GCA patient who I really want to make sure they don't have a relapse. So they have hard to control diabetes, or a lot of complications related to the prednisone itself. It's going to be a challenge to have this person on 2 years of steroid. People generally tolerate this pretty well. It's an infusion-based medication. It's a monthly infusion, and so it's covered by Medicare. All right. I don't treat osteoporosis per se. We don't do that as rheumatologists at Virginia Mason just because we stick to purely autoimmune conditions, but because I'm causing a lot of osteoporosis with my treatment of GCA and PMR, I would be remiss if I did not highlight the 2022 guidelines for glucocorticoid-induced osteoporosis. I'm sure a lot of people in this room do much better job treating osteoporosis than I do. But just as a reminder, if you're seeing patients who are being treated by a rheumatologist with steroid, the recommendation is for any adult, regardless of age, if they have been on steroid of more than 2.5 milligrams for more than 3 months, and if they've never had a fracture assessment, then they should get a DEXA scan. And so I think we are missing a lot of younger people in rheumatology just because we have sort of a hard age cutoff and we're forgetting about them. And similarly, a lot of men I see who, maybe they're 62, they have a new PMR diagnosis, they've never had a DEXA scan. So those are people who are getting missed, and those are people who should be getting a DEXA scan. And then basically, we want to be able to do that within 6 months of them starting their treatment. And then if they're going to be on continual treatment, like a lot of these people with PMR and GCA, maybe we should be doing that every 1 to 2 years, depending on what the results show if we don't start them on treatment. And I put the link here to those guidelines. Real quickly for lupus updates, this is not as recent, but I do like these guidelines. So in 2019, the European League Against Rheumatism, which is the European version of the American College of Rheumatology, and the ACR created new classification criteria for lupus that are really pretty straightforward. They simplified things a little bit. You'll see at the top, well, you can't probably see it, but at the top is the entry criteria, which is you have to have an ANA of greater than 1 to 80 to even think about lupus. And that was part of the prior criteria, but it wasn't quite as clearly laid out. So if someone has a negative ANA, they don't have lupus. If someone has an ANA that comes back from your lab of 1 to 40, they don't have lupus. We should be using a different cutoff for ANAs, and every lab does it a little differently. Virginia Mason, our cutoff is actually 1 to 160, similarly at the University of Washington. But they use the criteria of 1 to 80. And if I have a very high suspicion that someone has lupus and for some reason their ANA is coming back negative, we can redo it a different way. And I've never found this, but you could theoretically see if they have an ANA of 1 to 80 instead of 1 to 160. So if they have a positive ANA, meaning 1 to 80, then you kind of go through the rest of the criteria. You have to have something from both the clinical criteria and additional criteria from the immunological domain. And I think this criteria is helpful because if you're worried about lupus, it will tell you what labs to order, right? And so the labs that we worry about based on these criteria, hematologic, so I'm looking for leukopenia, thrombocytopenia. So I would love to see a CBC in anyone who's being sent to me to ask if they have lupus, because that's right there in the criteria. You'll see renal involvement. So I would love to see creatinine and urine with protein to anyone who's coming to me if you're asking if they have lupus. And then on the other column there, low C3, C4, those are complement levels. That is super helpful to include on your testing. You'll see antiphospholipid antibodies. That probably I would only suggest testing if someone has a clotting history, but technically that's part of our classification criteria regardless of clotting history. And then our lupus-specific antibodies, so a double-stranded DNA and a Smith antibody. Those are the only antibodies that are specific for lupus. Those are the only antibodies that matter in a lupus classification. So an RNP, the bane of my existence, false positive up the wazoo, is not in this classification criteria. And so we're happy to see people who have a low titer RNP, which is everyone in Washington State, but the labs that really matter and the labs that I would love to see and that will facilitate our first visit are a Smith and a double-stranded DNA. Okay, now when should you be ordering ANA? Basically, you should order an ANA if you are wondering if the patient has an ANA-associated rheumatologic condition. There are 5 rheumatologic conditions that are associated with a positive ANA. So lupus, and then drug-induced lupus, if we'll count those separately, scleroderma, autoimmune myositis, and there's 2 different types, polymyositis, dermatomyositis, and then Sjogren's. Those are the only rheumatologic conditions that are associated with a positive ANA. So if you're wondering if a patient has rheumatoid arthritis or psoriatic arthritis or ankylosing spondylitis or polymyalgia rheumatica or giant cell arteritis or anything else, it doesn't matter to me whether they have a positive ANA or a negative ANA because it's not part of the picture. I'm using other criteria. So all of that is to say, if you order an ANA, let's try to do it if we're looking for these things. The other time I think it is helpful to order an ANA, which is really you are indirectly looking for these things, is if you have a young person who has Raynaud's, you know, that triphasic color change in their fingers, white, purple, red, with cold exposure, or an older person who has new onset Raynaud's, then those are people who I'm worried that they're developing scleroderma, they're developing an autoimmune myositis, they're developing lupus. Raynaud's is common. It's not a surprise if you've had Raynaud's your entire life. But if you have a young person who's bothered by this and they want to just test one time, or if you have an older person and this is new, then that's worrisome. And I think you should check that. I don't treat children, but an ANA is an important part of is a prognostic indicator in juvenile idiopathic arthritis. It tells us how worried we should be about uveitis and eye involvement. All right, there's been a few updates in lupus management. I'm not going to get too far into the weeds here, but all of this is just to say that we had not had an FDA-approved medication for lupus in 150 years. And then in the last 4 years, we have had 4. And so this is very exciting, and we haven't quite figured out who is going to be on what medication and who's the best fit for all of this, and we're figuring all of this out. But this is awesome, and I'm very hopeful, and a lot of this is targeting lupus nephritis, which is certainly one of our more devastating diseases. And so these are expensive medications, as you can see, and they're immunosuppressing medications, and they don't come without risks, but this is really hopeful. Another thing that is really cutting edge in lupus, which is something that's actually kind of old, that's new again, that we're trying again, are stem cell transplants. And this is above my pay grade as a rheumatologist, clinical rheumatologist. But this is just to say that this is something that's starting to happen a little bit more. And this was just published last year, the 15-center pooled trial. They did hematopoietic stem cell transplants on about 300 patients. They had disease-free survival off immunosuppression in about 60% of people at 5 years. That's very impressive. Now, the reason we stopped doing stem cell transplants in patients with autoimmune disease many years ago is because they were all dying from the infection. So what's interesting about this is they have been able to get their treatment mortality down from 12% to less than 5%. And so that is hopeful, because basically that was always the trade-off is, are you going to die from your stem cell transplant, or, you know, is it worth just sort of slugging it out with your immunosuppressant medications? And obviously this is not a first, second, third, fourth line thing that's happening. These are patients who are on multiple immunosuppressing medications. They're probably on dialysis. There's a lot happening. But there is an actively enrolling trial for Treg cell-based therapies doing this at Swedish. So if you have anybody who's a candidate, let us know. All right, this is basically just saying that these are very sick patients and they seem to be doing very well. And so this is exciting, and I think more to come, but this is definitely not ready for prime time. All right, in my last few minutes, I wanted to talk about a brand new disease that we have discovered, or the NIH has discovered in the last year. that is at the moment falling in the rheumatology category. We'll see where this ends up shaking out, like a lot of different diseases. First, it ends up in rheumatology, and then we figure out who it really belongs to. But this is VEXAS syndrome. So VEXAS syndrome is an inflammatory disease that has a lot of hematologic manifestations. So VEXAS is an acronym. It stands for vacuoles, which are seen in the bone marrow biopsies of these patients. E1 ubiquitin activating enzyme, which is encoded by the UBA1 gene, which is mutated in patients, which is how we make the diagnosis. This is a commercially available genetic test. That gene is on the X chromosome. These patients have an autoinflammatory presentation, and the mutations are somatic. So that means they're acquired at some point in life, they're not inherited. And so typically these patients are older men, most commonly in their 60s or 70s. They are presenting with very painful skin rashes. They're getting sores in cartilaginous areas, in particular ears, nose. They have a lot of pulmonary involvement. They're very short of breath, and we cannot figure out why. There's nothing showing up. They have joint pain and swelling, and then they're showing up with basically kind of pseudovasculitis, so peripheral vasculitis. They have fever, they have extreme fatigue, they have anemia, thrombocytopenia, they're clotting, they're bleeding, they're very sick. Probably in retrospect, a lot of our patients who we've been calling and treating relapsing polychondritis and Sweet syndrome and polyarteritis nodosa and myelodysplastic syndrome, probably a lot of these patients actually have VEXAS. And Jane Buckner, who's a rheumatologist at Virginia Mason, is an international expert in relapsing polychondritis and has a huge cohort of relapsing polychondritis patients who she follows. And she is now testing every single one of her relapsing polychondritis patients for this gene. The problem is there's no treatment for this. So at the moment, it's more of an academic interest. Like a lot of things, we try to treat the underlying cause if there is one. And so if we can identify a hematologic malignancy that's associated, we're handing these people off to hematology, and, maybe down the road, they'll be eligible for bone marrow transplantation. Unfortunately, a lot of these patients require just very high doses of steroid for a very long time. We have not figured out what type of immunosuppression seems to work for them. Okay. And then in my last 2 minutes, I just included here for your pleasure reading later, the 2022 guidelines on the perioperative management of immunosuppressing medications in our patients who are undergoing surgery. Technically, this is for hip and knee replacement. I'll tell you that we at least extrapolate this to all surgery. So if you ask me what to do with an immunosuppressing medication, I refer you to this. The gist of it is for most surgeries, and maybe the only caveat to this is if there's like a huge open intra-abdominal surgery with a super high risk of infection, we continue DMARDs, the typical disease-modifying agents, the oral ones like methotrexate, hydroxychloroquine, sulfasalazine. We continue those through surgery. These are long-acting medications. They're not that immunosuppressing, really. The risks and benefit, in terms of the patient flaring, and is there any point in them being off the medicine for a couple of days or weeks? Not really. So we continue patients on these. They don't need to stop those medications before at least orthopedic surgeries in particular, and probably any minor surgery for sure. You'll see here that there are some lupus-specific guidelines. The gist of this is that you do not want a patient who has bad lupus to flare, because then whatever surgery they're getting, that is the least of our problems. And so the risks and benefit of continuing or discontinuing immunosuppression in someone who has bad lupus is a different conversation. And we should be involved in that, obviously. Probably we would love for you to continue a patient who has bad lupus, if they have to have a surgery, continuing them on their immunosuppressing medications for the most part. What do we hold and when do we hold it? I don't know how well this is showing up there, but our true biologic medications, we do want to hold before and after surgery. How often we hold them basically just depends on the half-life of the medication. And so that's essentially listed for you here. And it is a little tricky because some of these medicines are IV and some of them are sub-Q, and they have different half-lives depending on that. And so you're welcome to ask us or refer back to this. We have a clinical pharmacist who works with us at Virginia Mason who answers all of these questions all day long. If the patient calls with the date of their surgery, she will figure out exactly the date to start, the date to stop, and help them through all of that because it can get a little complicated. So that's all here. And then the last topic I have are vaccinations. So as probably many of us know, last year we had an update in general for immunizations. It was a little unclear where our patients in rheumatology fall. So, there's sort of this vague immunocompromised, excluding HIV infection classification. And so probably we put our patients there, but because it's not totally clear, the American College of Rheumatology came in and issued more specific guidelines. So I have one quick question for us here. So, this is topical. Okay, it's November. We have a 22-year-old patient with rheumatoid arthritis who's on methotrexate. They recently started adalimumab, which is Humira, in your office. They're in your office for their annual check-in. They have not had any vaccinations since their childhood vaccinations. Which of the following vaccines are correct to give them today, according to the American College of Rheumatology? Flu shot and hold their methotrexate for 2 weeks. Flu shot and hold their Humira for 2 weeks. High-dose flu shot, pneumonia shot, recombinant zoster, HPV, Tdap, and hold the methotrexate for 2 weeks, or none? Yes, so we love vaccines as well in rheumatology. So D is the right answer here. So in 2022, although this was just published actually this year, and there's a link down here that will bring you to the PDF because it is long. The ACR published guidelines specifically for our immunocompromised patients, what to do with their vaccinations. I think the one thing I would love everyone who gives vaccines to take away from this is that we are holding methotrexate for 2 weeks after flu shots as we head into flu season. This is based on pretty good data that the flu shot is much more effective if people can skip 2 weeks of their methotrexate after the vaccine. It is safe to get the flu shot and take your methotrexate. It's not a problem, but the flu shot will be more effective. And we would love for all of our patients who are on immunosuppression to get a high-dose flu shot. Insurance companies don't care about that. They will not reimburse it unless you're age appropriate. But I give my patients the option if they want to pay out of pocket to get a high-dose flu shot, even if they're not appropriate age, and most of them are willing to do that. Now, the studies have not been done for other vaccines. So technically, this recommendation of holding methotrexate doesn't apply to other vaccinations, but probably it does. So in general, I would love for all my patients basically to get as many vaccines as they can on one day and then skip 2 weeks of methotrexate after that so that they're not off their methotrexate for many weeks at a time. And then the other kind of main consideration is patients who are on rituximab. So rituximab is a every 6-month anti-B cell therapy. It wipes out an entire generation of B cells. You need our B cells to generate antibodies. You need to generate antibodies to have a vaccine response. And because it lasts for 6 months, if you have a patient who is on rituximab, there is unfortunately no point in giving them a vaccine unless their last rituximab was over 5 months ago. So it's good if you happen to catch this, and it's hard because often Rituxan isn't listed in their med list, and the patient doesn't remember when they got it, and but if you can catch them, right before they're going in for their next Rituxan infusion and getting all of their vaccines done 2 weeks or so before their infusion, that's great, because often I'll miss them, and now now we're heading into flu season and they're completely unvaccinated. So these are the other recommendations in here. There are recommendations about what to do if patients do need a live vaccine. So I get this question a lot. I refer back to this every time because it's hard to remember that if we only need to hold medications and worry about medications for live vaccines. If it's not a live vaccine, and remember the new shingles vaccine is not a live vaccine. HPV is not a live vaccine. Most vaccines are not live vaccines. So in general, I have no recommendations against any vaccinations. If it's a live vaccine, then we do have to hold immunosuppressing medications before and after so that we don't give the patient this. And then the question that I've been getting every single day in clinic is about the RSV vaccine. I don't know if we talked about this yesterday at all in this conference, but as of yesterday, which is the last time I looked, there is not a special recommendation yet for RSV vaccination in immunosuppressed patients. So everyone is asking me, and so far I am telling them, as far as I can tell, it's anyone over 60 is getting the RSV vaccine, but nobody else, regardless of how immunosuppressed you are. Okay. All right, so that is my talk. This is my email address. You're more than welcome to email me at any time. There are 8 full-time rheumatologists at Virginia Mason. We are, at this point, the biggest full-time clinical group in the state, and we are always happy to talk to people. You can call our office anytime. If you want me to talk you out of ordering an ANA, I'm happy to do that anytime. If you want to just run a case by us, we're happy to do that. If you want to ask us what lab should be ordered before you send the patient. I will say our referral process is such that we don't, as physicians, we don't see the referrals until the patient is in our exam room. So if you have an urgent patient, you have to pick up the phone and call us, and then we will get the patient in to see us. Otherwise, it'll probably be a 4 to 6 month wait. But if you have a GCA patient and you call us, we will see them the next week. We'll make it happen. Just call me. Okay. All right. Thank you, everybody.